We're going to get started with the afternoon session. So as you're happily digesting your lunch. So we had a transthyretin morning, and we're going to have a light chain kind of afternoon. Doesn't that sound kind of nice? There's a nice ring to it. It's my honor and privilege to introduce our next speakers. We have Dr. Vaishali Sancharawala here from Boston Medical Center, Boston University, and she's of course a world-renowned hematologist, expert in amyloidosis. So we're very grateful that she's here today with us. And also my pleasure to introduce my good friend and colleague, Dr. Christopher Venner, who's a hematologist and again, world-renowned expert in amyloidosis, who was in Alberta a few years ago, in Edmonton, and now is in Vancouver. And we also happen to share the same hairdresser, of course, as many of you already know.
Old photo, clearly.
Yeah, that's right. So, anyway, they're going to talk about advancements in the treatment of AL amyloidosis, a comprehensive review of Canadian treatment recommendations. So thanks very much both for being here.
So good afternoon, everyone. Thank you to Dr. Fine, Dr. Jimenez Zepeda for inviting me here. And it's a true pleasure and honor to present to all of you what we have accomplished in the last 3 decades of AL amyloidosis or light chain amyloidosis. These are my disclosures. Okay, maybe not.
I think it's the other, yeah, down.
This?
Down button.
Oh, okay. Yeah. That's why. Oh, God.
Yeah, no,
Oh, my God.
It's not intuitive.
Right. Okay, I can take care of patients with AL amyloidosis, but I can't really figure out the remote of this presentation. Okay, so this is the title of my talk. I'm going to just give you an overview of what this last 4 decades have brought to us in treatment of AL amyloidosis. These are my disclosures. I get a lot of research support from all these companies. And this is a longitudinal natural history study of 40 years from Boston University Amyloidosis Center of approximately 2,500 patients with systemic AL amyloidosis seen over 4 decades. And we have seen that the median overall survival of patients with AL amyloidosis have improved dramatically from 1.4 years in the mid-1980s to 4.6 years in the recent era of 2010 to 2019. And this can be attributable to the expanding therapeutic landscape of AL amyloidosis. And majority of these treatment regimens listed over here, which probably to the cardiologists and neurologists are the alphabetical soups, are derived from those in multiple myeloma. None of these treatment regimens are approved by the regulatory agencies for the treatment of AL amyloidosis, except for daratumumab, cyclophosphamide, bortezomib, and dexamethasone, which was approved in 2021. I'm going to focus or divide my talk into treatment of newly diagnosed AL amyloidosis and treatment of relapsed refractory AL amyloidosis. High-dose intravenous melphalan and autologous peripheral blood stem cell transplantation was first developed for the treatment of AL amyloidosis in the mid-1990s at Boston University Amyloidosis Center. This treatment was developed development of this approach was prompted by promising results of similar regimens in the treatment of multiple myeloma, which is a cousin of AL amyloidosis, a plasma cell dyscrasia. Objectives of the initial clinical trials were to determine tolerability of this aggressive treatment approach in patients with multi-system organ involvement. 2, to determine efficacy of this treatment in inducing complete hematologic response. And at that time, we argued that the plasma cell burden in AL amyloidosis is much lower than that in multiple myeloma, and hence this treatment would probably have higher hematologic responses. and finally to determine whether complete hematologic response leads to reversal of amyloid-related organ dysfunction and improved survival. Prior to 1990s, the treatment of AL amyloidosis was again derived from multiple myeloma and was on oral melphalan and prednisone and two pivotal randomized historical placebo-controlled trials, one performed at Boston University and other one performed at the Mayo Clinic, showed that the median overall survival did improve with oral melphalan prednisone in the range of 12 to 18 months. However, this treatment was rarely inducing complete hematologic response, long-term survival, or even organ dysfunction improvement. Dr. Comenzo, who's not here in the audience but is going to be the next speaker, he described our first 5 patients who were treated with stem cell transplantation for AL amyloidosis with some impressive and encouraging results. Long-term outcome of first 80 patients who underwent stem cell transplantation at Boston University Amyloidosis Center did show that the median overall survival was greater than 10 years for those who achieved a complete hematologic response compared to 4.1 years for those who did not achieve a complete hematologic response following stem cell transplant. We then ended up looking at our 25-year experience of stem cell transplantation in AL amyloidosis in 648 consecutive patients treated with stem cell transplantation for AL amyloidosis. The purpose of this analysis was to address durability of hematologic response achieved after stem cell transplant and also to address long-term survival and complications of this intensive treatment regimen. Several sequential IRB-approved clinical trials were performed at our center, and the age, renal function, time from diagnosis, prior treatment, and conditioning regimen varied among clinical trials. However, the broad eligibility criteria for stem cell transplant in AL amyloidosis were tissue diagnosis of amyloidosis, Congo red positivity, apple green birefringence, and evidence of plasma cell dyscrasia, and at least one vital organ involvement. Other eligibility criteria included minimum measures of performance status, cardiac function, pulmonary function, and hemodynamic stability. 648 patients have undergone stem cell transplant, and majority of them have received full high-dose melphalan at 200 milligrams per meter square, and 40% of patients have received modified high-dose melphalan. 10% of these patients also received bortezomib-based induction therapy. Hematologic response following stem cell transplant was evaluable in 90% of the patients. Hematologic complete response, defined as absence of monoclonal protein in serum and urine by immunofixation electrophoresis, normalization of serum free light chain ratio, and bone marrow biopsy showing less than 5% polytypic plasma cells, was achieved by 39% of the evaluable patients, and on an intention to treat analysis, it was achieved by 35% of the patients. The median duration of complete hematologic response was 12.3 years following stem cell transplantation, and only 5% of patients had a hematologic relapse if they remained in hematologic complete response for 15 years or more. Median event-free survival, whereas an event was defined as next line of treatment for clone-directed therapy, or death, whichever occurred first, was 3.3 years following stem cell transplantation. With a median follow-up of living patients of 8 years, the median overall survival following stem cell transplantation was 7.6 years, and the 10-year projected overall survival in the most recent era is 67%. Hematologic response also impacted overall survival following stem cell transplantation. Median event-free survival was 11 years, and median overall survival was 15 years for those who achieved a complete hematologic response following transplant. Treatment-related mortality, defined as deaths occurring within 100 days of stem cell transplantation, was 7.6%, and in the recent era, this treatment-related mortality has decreased to 3.3% based on better patient selection, experience of the treating physicians, as well as better supportive care and availability of other treatment regimens. Therapy-related myelodysplastic syndrome and acute myelogenous leukemia, the cumulative incidence following stem cell transplant at 25 years was 3.3%. Organ responses, our second objective, was also evident following stem cell transplantation. The deeper the hematologic response, better the organ response. It is important to note that the organ response takes time. The time from treatment initiation to best organ response can be anywhere from 2 to 3 years, as noted in the last column. Organ responses after treatment for AL amyloidosis is often incomplete, reflecting the complex interplay of host, disease factors, precursor factors, as well as therapy-related factors that may impede recovery of the organs. Other large experiences on stem cell transplantation in AL amyloidosis come from the CIBMTR, or the registry data of 1,500 patients, showing an improvement in 5-year overall survival from 55% in the mid-1990s to 77% in the mid-2000s. Mayo Clinic investigators also have reported on prolonged survival following stem cell transplantation, with an estimated 15-year overall survival of 33%. UK National Amyloidosis Centre reported on 264 patients treated with stem cell transplantation in AL amyloidosis, again showing a median overall survival of 8.2 years. There are no direct comparison of stem cell transplant versus non-stem cell transplant regimens in AL amyloidosis. This is from our longitudinal natural history study from Boston University, looking at the 5-year overall survival of patients treated in the most recent era, which has a 5-year overall survival of 76% for those treated with stem cell transplant and 42% for those treated with non-stem cell transplant regimens. Of note, these are not randomized controlled trials. These are longitudinal natural history study data. Mayo Clinic also has reported on overall survival at 2 years in their longitudinal natural history study. And again, in the most recent era, the 2-year overall survival was 94% for those who received stem cell transplant and was 47% for those who received non-stem cell transplant regimens. The role of transplant center was addressed in the CIBMTR study, showing that 30-day and 100-day mortality was significantly lower for the centers that do greater than 4 stem cell transplants for AL amyloidosis per year. We at International Society of Amyloidosis and European Hematology Association Working Group developed guidelines for stem cell transplant in AL amyloidosis. The working group consisted of an international collaboration effort with representation from 6 different countries, and these guidelines talk about eligibility criteria, patient selection, induction therapy, stem cell mobilization and collection regimen, risk-adapted melphalan dosing, as well as post-transplant supportive care. The role of stem cell transplantation is being questioned, and only 20% of newly diagnosed patients are eligible to receive stem cell transplantation. And this is because of the Andromeda clinical trial that was a phase 3 randomized controlled trial performed in multiple institutions across the globe, which has 388 patients with newly diagnosed AL amyloidosis who were randomized to receive bortezomib, cyclophosphamide, dexamethasone, VCD alone, or VCD plus anti-CD38 monoclonal antibody daratumumab. And the primary endpoint of this trial was a hematologic complete response, and patients who received VCD plus DARA had a complete hematologic response rate of 59% compared to 19% for those who received VCD alone. With a median follow-up of 61 months, 5-year major organ deterioration progression-free survival was 60% for those treated with DARA VCD compared to 33% for those treated with VCD. Major organ deterioration progression-free survival was a composite endpoint of death, hematologic progression, or organ failure, whichever occurred first. With a median follow-up of 61 months, the 5-year overall survival rate was also in favor of DARA VCD treatment arm at 76% compared to 65% for VCD treated patients. European Myeloma Network performed a randomized control trial of 109 patients who were not stem cell transplant eligible and were randomized to receive bortezomib, melphalan, dexamethasone versus melphalan, dexamethasone alone. And the overall hematologic response rate, overall survival, and progression-free survival were in favor of a triplet, which is the bortezomib, melphalan, dexamethasone arm. This is one of the first trials to really show an overall survival advantage of bortezomib-based therapy. ISA and EHA have developed guidelines for non-stem cell transplant chemotherapy, which is 80% of the patients who require this for treatment of systemic AL amyloidosis. These were published in the Amyloid Journal in 2023. Moving on to treatment of relapsed AL amyloidosis. Again, I usually don't show this slide, but since Dr. Kukrat is here, I'm going to talk about this, that the criteria, because we are developing something similar to this as a collaborative group, that the progression, when do you really begin second line of therapy? And there are no validated hematologic progression criteria. Do you begin therapy at the time of first uptick in the free light chain? Do you begin therapy in patients who are still in remission but are now having organ progression? So these criteria are not really validated and not well defined. The criteria that are more recent are from 2018 from the Italian group, noticing that high-risk DFLC, so difference between involved and uninvolved light chain progression criteria, are listed here, which are absolute value of DFLC greater than 20 milligrams per liter and DFLC level that is at least 20% of the baseline value and DFLC that is at least 50% higher than nadir DFLC. Nobody can remember these criteria. Still have it on. I used to have it as a laminated card in my pocket. Now I have it in my notes section. And, I can't even calculate because I'm not a mathematician. Having said that, we generally as clinicians don't follow these criteria. I had to put this slide in there because Donna Reese, who's a great friend and a mentor and a colleague, we worked on this together as CAN 2007 trial, published in 2014, almost 11 years ago. This was a multi-center international clinical trial of single-agent bortezomib in patients with relapsed AL amyloidosis. And single-agent bortezomib produced a durable hematologic response and promising long-term overall survival in patients with relapsed AL amyloidosis. This trial also showed us that once-weekly bortezomib is better tolerated in this patient population and produces similar responses to twice-weekly bortezomib in this patient population again. Immunomodulatory agents, lenalidomide, pomalidomide, and now some new medications were studied as investigator-initiated phase 2 clinical trials at Boston University Amyloidosis Center, and this is a pooled analysis of 3 prospective trials with immunomodulatory agents in relapsed AL amyloidosis, incorporating 125 patients, showing that the median overall survival was 4.3 years and the median progression-free survival was 2.1 years. Turbil in AL1 is a phase 3 randomized clinical trial of ixazomib dexamethasone, an oral proteasome inhibitor, versus physician's choice therapy in patients with relapsed AL amyloidosis. This trial did not meet its primary endpoint of overall hematologic response. However, hematologic complete response, the duration of hematologic response, vital organ progression-free survival, and hematologic progression-free survival were all in favor of ixazomib dexamethasone arm. Daratumumab, a monoclonal anti-CD38 antibody, has been a game changer in patients with relapsed AL amyloidosis. This slide shows you an aggregate of all studies that have utilized daratumumab as monotherapy or with as a combination therapy in relapsed refractory AL amyloidosis, with an unprecedented high hematologic overall response rates of 80 to 90% and hematologic complete response rate of 40 to 50%. Isatuximab, another monoclonal anti-CD38 antibody, was studied in relapsed AL amyloidosis through Southwest Oncology Group as a multi-center national clinical trial, and again showing in this 43 patients showing an overall hematologic response rate of 77%, and this translated into organ responses as well. Bendamustine, we don't utilize this anymore, but it is an alkylating agent which was studied as a phase 2 clinical trial in relapsed AL amyloidosis, again having a response rate of 57% partial response or better, and those who achieved a hematologic response had a better overall survival. AL amyloidosis, translocation 1114, occurs in about 40 to 50% of patients with AL amyloidosis. It is the primary mutation or the driver mutation. And we have a small molecule that is a BCL2 inhibitor. And in this retrospective study of multi-centers, venetoclax, which is a small molecule, led to hematologic response rates of 78% in those who had translocation 1114. Some prospective phase 2 clinical trials are ongoing. Can we do personalized medicine? Cytogenetic abnormalities in AL amyloidosis, such as translocation 1114 and 1q gain, have significant implications for treatment responses and survival with different treatment regimens, bortezomib, venetoclax, and daratumumab, showing variable efficacy depending on the cytogenetic profile. This slide summarizes the current landscape of B-cell maturation antigen-directed therapies in AL amyloidosis. The left panel on the slide highlights the breadth of immune-based strategies being investigated, all covering and converging on the BCMA as the target, and they are being studied and are approved for treatment of multiple myeloma. The bar graphs on the right side summarizes the published results of retrospective case series from different centers of this BCMA-based therapy. The first one is the belantamab mafodotin, which is a antibody drug conjugate, again showing an overall response rates of 55 to 75%. Teclistamab, which is a BCMA CD3 bispecific antibody, has shown unprecedented high response rates, overall response rates of 100% in multiple studies. And then we have BCMA-based CAR-T therapy, which also can lead to very, very high hematologic response rates in patients with relapsed AL amyloidosis. These are two retrospective studies from single institutions of teclistamab, which is a BCMA CD3 bispecific antibody, again showing not only high hematologic response rates, but rapid hematologic response rates with a median time to hematologic response of less than a month, 18 to 28 days. Elranatamab is another BCMA CD3 bispecific antibody, again studied in an investigator-initiated phase 2 trial of 9 patients, showing high hematologic response rates, good safety profile, and organ responses as well. This is a novel academic CAR-T therapy HBI-0101, developed in Israel and was presented at multiple meetings at ASH, and now has been published in Journal of Clinical Oncology, where 11 patients with relapsed AL amyloidosis and multiple prior lines of therapy received this particular CAR T therapy, had very high hematologic responses as well as organ responses. However, 6 out of 11 patients were experienced death because of either cardiac events or because of COVID-19. Again, you know, these patients were heavily pretreated and their hearts were too far gone. A phase 2 clinical trial of Nexicart, it is a BCMA CAR T, again, is ongoing currently in the United States, and Heather Landau has presented the data on 10 patients in June at ASCO 2025, showing that with a median follow-up of 171 days, the hematologic complete response was achieved in 100% of the patients. There was one death which was unrelated, but related to end-stage renal disease and infection. So I think we have gotten quite good at suppressing the amyloidogenic precursor protein production, ablating the plasma cell dyscrasia, achieving complete hematologic responses by clone-directed therapies. However, we all know that we have patients who present with end-stage renal disease, end-stage cardiac disease, and we need treatments to really improve quality of life and organ dysfunction of these advanced patients. We need molecules that can stabilize the misfolded light chains, or we need antibodies that can clear amyloid deposits from the organs. So light chain stabilizer, small molecule, tafamidis for AL amyloidosis, is being developed currently by Gareth Morgan, who's in our group, along with Protego Pharmaceuticals. And I think they are ready to begin their phase 1, phase 2 clinical trials soon. Antifibril agents, depleters, amyloid busting agents. Birtamimab was one of the first agents to be studied, and it was studied in Pronto phase 2b clinical trial. It was studied in phase 3 VITAL study, and it was discontinued because of futility analysis. However, in a post hoc unplanned analysis, it was noted that 9-month all-cause mortality and quality of life and functional capacity were better when patients were treated with birtamimab for Mayo stage 4 patients, so advanced cardiac amyloidosis patients. This trial then went on to have a confirmatory trial, AFFIRM-AL, and in a press release on 23rd of May 2025, the company Prothena announced that this clinical trial for birtamimab did not meet its primary endpoint, and development of this molecule was completely discontinued. Ensalutamide, or KALEM-101, also had some promising and encouraging data in phase 1A and phase 1B study with improvement in biomarkers and objective imaging modalities. This molecule also underwent phase 3 investigation in advanced cardiac AL amyloidosis, and on 16th of July 2025, Alexion announced that this program for ensalutamide in patients with AL amyloidosis did not meet its primary endpoint. However, they also had in the press release that it did show highly clinically meaningful improvement in survival and cardiovascular hospitalization in pre-specified patient groups. We will hopefully find this out more at the American Society of Hematology meeting. So are we ready to say goodbye to antifibril, anti-amyloid antibodies, unlike ATTR amyloidosis? So Suzanne Lynch at Columbia University is developing an anti-amyloid 11-1F4, so that is the ensalutamide, CAR phagocytes for treatment of AL amyloidosis to really clean out the organs with this CAR phagocytes. We will see what the results show. I did have to say that the supportive care is a fundamental part of an integrated treatment approach in this multi-system disease. It requires coordinated expertise of several subspecialists familiar with the disease, and the goals of supportive care are to improve organ function, maintain quality of life, and prolong survival. So supportive care guidelines are published in 2025, earlier this year, by the International Society of Amyloidosis. It is based on expert panel guidelines. And this is the multidisciplinary care model that we follow at Boston University Amyloidosis Center, which is an integrated care which helps patients and physicians navigate the challenges of this rare disease. It is a one-stop shopping. The patient stays in one room, and all the providers go and see the patient in the same room in an outpatient setting. And with that, I would like to acknowledge all the members of the clinical team and the basic science team who work on the scenes and behind the scenes to make this disease more manageable. And I would like you to be invited to the 20th International Symposium on Amyloidosis in Uruguay, in Montevideo, in November of next year. So thank you, and with that, I would pass it on to Chris, because I did say a lot of things, and I'm not sure what the Canadian treatment algorithm and treatment recommendations, what is available, what is not available. So Chris is going to go over all that with us. You want to sit here?
Oh, that's good. Yeah, thank you. Thank you, Vaishali, for that great whirlwind presentation. And there's a lot that's gone on in the field of plasma cell dyscrasias in general, but amyloid in particular, and trying to distill that into the Canadian landscape, as it is, I think, everywhere, a challenge. I'm going in the wrong direction. So these are my disclosures here. I'm just going to skip through this. I'm going to just do this a little more off the cuff and try and distill all of the information that Vaishali has put in, again, into that Canadian landscape. But we continue, as we always do in plasma cell dyscrasias, to break our patients down in terms of the frontline treatment, which is, especially in amyloid, a very different population than in the relapse space, predominantly because if you live long enough to relapse, you're actually arguably a relatively good risk patient. And then also this, the antiviral therapies, because there are some interesting Canadian bents to that. We hope we'll see some competition in that field too from our homegrown talent. We'll talk a bit about that. Just to kind of level set, this is not a common disease, but it's not an uncommon disease. And I'm preaching to the converted here because everybody here, it's near and dear to their heart. This is an interesting study, though, that looked at both the incidence of amyloid, but also the prevalence. And that prevalence curve, the bars there, going up exponentially as opposed to the incidence kind of staying the same, is why we are so challenged in clinic. We're a victim of our own success here. We have lots more patients than we ever did that are alive and well and living with this disease. And so kind of to Vaishali's point about supportive care and the ongoing need to monitor and manage these patients in a multidisciplinary fashion, that's ever more important nowadays. We've talked a little bit about staging, again, preaching to the converted. The biggest take-home message remains that the burden of the cardiac disease is still the most important. We love to do staging systems, and in particular, the Mayo Clinic loves to do staging systems, and they've looked at their data 1 million times over. Many people have critiqued their staging systems as well. Thankfully, they're simple. They're relatively straightforward to apply in most labs and most settings, which has been nice. But the take-home message, especially in the modern era where we have daratumumab and better anti-plasma cell-based therapy, is kind of summarized in curve C there. That bottom curve continues to go down, albeit better than it ever was, but that bottom curve reflects those patients that have the highest risk from a cardiac standpoint. And what is interesting is, as you apply some of the more nuanced ways that the Mayo has looked at things and trying to incorporate the plasma cell dyscrasia standpoint of things by looking at the light chain burden. The light chain burden is less important now because we have better anti-plasma cell-based therapies, but that cardiac burden remains a huge problem. So still somewhat of I shouldn't say insurmountable, but still very important aspect of the disease. And Vaishali also alluded to this, but the depth of response remains very key. Dr. Gilmore before also alluded to this. But this is really our best goal of therapy, especially as the hematologists, the ones that are responsible for turning the tap off. This is what we're trying to shoot for. And it's very important, and I think a nuance that perhaps even some of my hematologists don't fully appreciate. When you look at the light chains in this disease, that is the disease, whereas in the myeloma counterpart, it's more of a marker of the plasma cell burden. But for us in the amyloid world, we're really paying attention to even smaller changes. And that update that we have in both the response and progression criteria that was alluded to earlier, those numbers are quite a bit different than what we would expect in the myeloma world. For perspective, progressive disease, looking at light chains in the myeloma world, you expect to see the DFLC, the difference between the involved and uninvolved light chains, has to go up above 100 from the nadir. And in the amyloid world, we're looking at much smaller changes. Anything above 20 we really worry about, because that's implying that there is enough circulating amyloidogenic light chain to still cause problems and should be a trigger for us to reevaluate patients for potential therapy. So it's good to keep those things in mind when we're talking about the treatment options, when we're talking about clinical trial design, entrance criteria, and exclusion criteria as well. And because doing good clinical trials in amyloidosis is, I think, one of the hindrances we've had to really making advances that get to the clinic. So more practically speaking, when I see these patients in clinic, this is kind of the things that I go through in my own mind. The first question that I have has to do with drug access, and we ask, is there a concurrent diagnosis of multiple myeloma? And I mean, there's no secrets, especially in this room, but we are always trying to shoehorn patients into this. This is definitely a square peg in a round hole scenario, but if you can label somebody myeloma, then you get access to all of the myeloma-based therapies, which we know work. They work with different considerations, I'll say, in treating amyloid patients. But nonetheless, anything that is effective as an anti-plasma cell-based therapy, as proven in the myeloma space, will have activity in the AL world. We've, in BC and in Alberta, when I was there as well, and also in the UK, have taken the more European and old school UK approach for its symptomatic plasma cell dyscrasias, and that is to say there is a reasonable clone present, diagnosed in some way, shape, or form, and a problem. I mean, that is what myeloma is. It's just that the problem in myeloma is the Crab criteria. But it's not to say that those plasma cell clones are not important if they're small and not giving Crab, but they're giving amyloidosis. So in BC, we really focus on that percentage of plasma cells in the marrow or some other evidence of a plasmacytoma present, plasma cell clone present that is of reasonable burden. Thankfully, we have a little bit of latitude. But this is a very important exercise that we have to do with every patient. If the answer to that question is no, that we just can't put that square peg in that round hole, then our options are rather limited. And Vaishali mentioned this, the only approved therapy for AL amyloidosis is Dara-Cyborg-D, and that was based on the registration trial through Janssen, that was the Andromeda study. Stem cell transplant is technically approved. It's kind of grandfathered in, as is the old school therapies like melphalan and dexamethasone, because they're relatively cheap. Even transplant compared to what we're looking at now is a relatively cheap strategy. But transplant is still only available to about 25% of patients at most because of how we have to select those patients. And if we do it in an unselected way, patients die, just to be blunt. And then we also still need to pay attention to the responses of our initial frontline therapy, depending on how we do it, so that we can move on to the next treatments quickly and arguably more quickly than we may otherwise do in the myeloma space. So although Dara-Cyborg-D is often the default for the vast majority of these patients, we are really paying attention to that month-to-month, cycle-to-cycle assessment and then pivoting where we can. And the other editorial note I'll make, despite all of the cool things that Vaishali had mentioned, we don't have anything approved in the relapse space. And this is a major challenge in Canada. CDA doesn't have any recommendations for relapsed AL amyloidosis, and nor do we have it funded in any official capacity in most provinces. So this is where we struggle. If the answer to that previous question is yes, as I alluded to, we have many treatment options available if they have that concurrent label of multiple myeloma. Still all the same disease, but the label is important. Semantics are important. Daracibord still remains probably the treatment of choice for these patients. It's kind of the devil we know. And truly, if they do have a higher burden of plasma cells in the marrow, we do have to think of them a little bit more as a myeloma type patient. And one of the crossroads we often come to for all these folks is, what do you do at the end of the 2 years of maintenance? Are you happy that they will be like our Andromeda patients and they are going to be 10 years out and doing well? Or is the myeloma aspect of things going to catch up to them? And do you need some more chronic long-term myeloma suppressing therapy? And this presents a bit of a conundrum. It's good to have the option technically for a myeloma patient with amyloid to be able to perhaps even pivot to darolutamide and dexamethasone. But we don't have a lot of great data that that's the right decision. So I'll leave that as a bit of a question. We'll talk about some of the data that may help us or arguably may even make it more confusing over time. We do have more options at relapse, and so many of those cool anti-BCMA therapies and other things, if you have that myeloma label, they are potentially on offer for those kinds of patients. Where we are hoping to get more data, though, is how to deliver it. Because, again, amyloid patients are different. Dealing with cytokine release syndrome in a very sick amyloid patient is a different ballgame than a standard risk myeloma patient. So, again, there's always nuance when you add that dysproteinemic condition. This is the Boston study. This is something that I go back to all the time, and these real-world series are extremely important in this disease. All of our clinical trials fall short because the follow-up is too short. So the Boston group, the UK group, Mayo, anybody that is committed to following these patients out 15, 20 years and presenting this data is really crucial because it helps to put into context the cool new things that we have. So this was really one of the seminal studies that demonstrated how good things could be with a transplant if you achieve those deep responses. And you can see that in the curves on the right here. So if you achieve a complete response with transplant, your event-free survival at 4 years, 75% are still disease-free, which is amazing, and the median progression-free survival is approaching 10 years. And that's with old-school kinds of treatments. But good to keep this number in mind, especially the 75% at 4 years. This is some work, I'll quote myself, I guess, on this one, but it is a question that comes up often. Can you defer transplants? Is there a downside to deferring transplants? And there's lots of trials that are out there trying to explore this or using consolidative approaches and things. But a simple question that we had, and this is now pretty old data, was what was the outcome of patients if they were transplanted at relapse versus at the beginning? And the long and short of it is that, especially in amyloid where the plasma cell burden is low, it still seemed like you could do just as well with a transplant later. So this is important in a disease that has the potential to play out over a decade or more, thinking about the timing of the transplant side of things, especially as we get better non-transplant things up front. And this is some of that data around consolidative approaches, which is particularly important. And these two studies actually took an approach, I think, that is more like how we would manage these patients today, taking patients that had some sort of an induction, either daratumumab-based or bortezomib-based, and didn't do as well as you would want them to at the beginning. And then the question was, could you improve upon that response with the transplant? And the short answer is yes. In that highly selected group of patients that was eligible for transplant, you could get quite competitive and results that were consistent with what we know of transplant. So to answer the very blunt question of who should be transplanted, from a Canadian lens and knowing what we have funded, I'll make the provocative statement to say no one. And I know our colleagues down south may disagree with that, but the reason for my statement that way is, first of all, very few patients actually qualify. The plethora of folks that we see come through our clinic, 25% or less would meet the criteria on paper. The second biggest one is, what do we have options for if we do transplant at the beginning and those folks relapse? And the answer, unfortunately, especially if they're just a straight up amyloid patient, is nothing. The only crack we have of obtaining daratumumab is if you use it in the frontline setting, and many provinces don't offer a lot of latitude there. If you fail to use Dara first line in the context of Dara-Cyborg-D, you will never get it again. So the approach that we've taken in British Columbia anyway, and I think many other provinces have gone this way, is to say basically nobody is transplant eligible at the beginning. There are very few folks that would not benefit from some initial therapy to improve their overall organ function and functional status in general. And they should get a crack at that first, and then you decide on the transplant at a later date, spurred on by either failure to respond to Dara-Cyborg-D, because it's not a panacea for everybody, or after a great response to Dara-Cyborg-D and then relapse occurs even years later. Those patients arguably are even in better stead to get the transplant at that point. Vaishali has already presented this. I won't belabor it, but Andromeda did change the face of this disease for us, so we cannot downplay that at all. But just to put it into perspective too, if you look at the curve on the left, looking at the modified PFS endpoint, we think about that 4-year mark that I showed with the older Boston data there. Arguably, Dara-Cyborg-D is at least as good in terms of the durability of the response. It's arguably better at the depth of response, because there is lots of questions, or at least there had been lots of questions like, is Dara-Cyborg-D just as good from a durability standpoint? And I think the longer we follow these curves, the answer is yes. And more importantly, it's applicable to a wider swath of patients. So the inclusion criteria for this study was patients that were Mayo stage 1 all the way up to stage 3As. So still pretty sick patients, just not the sickest of the sick, not the 3Bs. Now, speaking of 3Bs, a question we often come to in the clinic is, what do we do with those 3Bs? How do we treat them? And again, there's a lot of nuance here. Broad strokes, though, daratumumab works, bortezomib works. Dexamethasone is a very hard drug to give. Arguably, you don't need to give it, or should be very cautious if you choose to do so. But these curves, and again, looking at real-world experience, really exemplify how good this drug, and especially the daratumumab, has been. And if you look at those curves, so the 3B curves without any kind of daratumumab-based approaches, that's the blue curve on the far left there. That's been that curve for years and years. Without advances in anti-plasma cell therapy, those bad patients, the 3Bs, they just go straight down. With daratumumab-based regimens, having this plateau of a curve is remarkable. These are the sickest of the sick patients, but we can take those 3Bs and have over 50% of them still alive at a year, and that is unprecedented. So these drugs, and Dara in particular, is important. It works because it drops the light chain levels very quickly. And light chains in amyloidosis are toxic in other ways beyond just laying down the amyloid. So having that more immediate light chain control is key. And so these types of data are important in giving us confidence that we can treat these sick patients, gives us a benchmark that we can shoot for in terms of outcome. And then also to encourage us to be smart in how we give it. And you don't have to give the full whack, the full Dara-Cyborg-D as it is in the trial right out of the gate. You can trickle things in these really sick patients. So give a bit of Dara first, cycle or two even, be very judicious with the steroid component, and then layer in the bortezomib as you feel you can. And if we do that, I think this is how we get these curves as they've evolved here. Lenalidomide and dexamethasone, for those hematologists in the room, is an option. It's a tantalizing option given how it's changed the face of multiple myeloma. It'd be interesting to hear what our other hematology colleagues say. First of all, we don't have a lot of data at all for DRD and amyloid, which is unfortunate because it should be a good regimen. We have a small study like this one, which is relatively encouraging. VGPR rates are better of 60%, but there was like 10 patients in this study. So how do we glean much from this? And the gestalt in the clinic is that the IMiDs just didn't pan out as well as the proteasome inhibitors did in amyloid. And I can't really put my finger on it, but there is this this issue. And maybe it has to do with expectations for different time points in the disease. Lenalidomide remains a very tantalizing thing for long-term disease control. And so maybe it does have a role in those patients that are more further down that myeloma spectrum. So this is the summary. I've kind of alluded to this already. Basically, our approach for frontline therapy for amyloid in Canada is everybody gets Dara-Cyborg-D. You can modify the introduction of all of the regimens, the 4 regimens in this cocktail, based on the patient sitting in front of you. But again, just to give you some confidence that you can even treat 3B patients. All is not lost, even for those really sick ones. And to really pay attention to the response. There may be patients who have a suboptimal response where you could roll the dice and treat a more high-risk patient with a transplant, for example, early on if they were refractory to Dara-Cyborg-D, or use that response to trickle in transplant or other things in relapse at a much sooner time point based on their light chain levels. So second-line therapy, again, we've alluded to the big conundrum here is we don't have a lot of approved agents, but the goal is important. I mean, this is a growing population, thankfully, again, a victim of our own success. We have more and more patients that respond really well to frontline therapy, thus more and more patients in our clinic in whom we will have to give relapse therapy to when the time comes. And the goal is a bit different in the relapse space. In the relapse space, we've already fixed the problem. In fact, many of these patients have had amazing responses and returned to a reasonable quality of life. So now our job as hematologists is to try and stay ahead of the game and try and prevent them from going back to where they were when they initially presented. And so that's really what spurs on our decisions to treat. Again, these were already alluded to. Our options in relapse are, IMiDs, we've explored this, carfilzomib even as a second-generation proteasome inhibitor, somewhat underwhelming, I guess, as doublets, or challenging. So carfilzomib, it has promise. It's a very good proteasome inhibitor, but with the cardiotoxicity that goes along with it, that can be quite challenging in our amyloid patients. So take-home message from this slide is this is great data, but I think we can build upon this and do better. It's tantalizing to use a Dara-bortezomib-based combination again at relapse, and actually using Dara in the second-line space is very good. VGPR rates of 70% or better, which is, again, exceptional and somewhat unprecedented, along with the durability of responses that you're seeing here for those patients that do well and get those VGPRs and CRs. Isatuximab is the other anti-CD38 player, and in combination with pomalidomide, this is presented at ASH last year. Again, really great depths of responses, and this is quite a well-tolerated regimen, which I think you could give to a much wider proportion of our relapse patients, so encouraging. Great if you have that label of myeloma, because we can access this in Canada. It would be funded in that situation, but not if you're just a good old-fashioned amyloid patient. So access, again, is a huge problem for us. Venetoclax was also discussed. Again, our problem in Canada is one of access, so hopefully this will come through. Hopefully our pharmaceutical colleagues will come through for us here, because they have a responsibility in developing trials that will lead to funding, that will be registration level. And that is equally for the FDA, for our colleagues in the US, but also the CDA and Health Canada, and then most importantly, the Pan-Canadian Pharmaceutical Alliance, which negotiates price. So the data has to be more than just response rates. It has to demonstrate durability and things that we can negotiate on. The anti-BCMA approaches, Vaishali already presented this slide. There's a plethora of them out there. It cannot be understated how amazing these responses are. 90% VGPR rates or more, some of these series 100% CR rates. And this is only going to get better. Like, we are seeing 100% MRD negativity rates when we're using bispecifics in the frontline setting in myeloma. Of course it's going to work in amyloid. But how do we, again, develop trials that are going to get these things there? So this is, I think it's my summary slide for the anti-plasma cell-based therapy. I won't read all of these things, but suffice it to say we have options. We have a growing number of options. Where we really are lacking, the big gap that we have is data and usable data to get these drugs to our patients. And advocacy. I think we actually do need to re-engage with Health Canada, with Canada's Drug Agency, to acknowledge that this does still fall under that rare diseases category, and maybe we do need to look at the data differently. Maybe we need a different model for partnering and negotiating with our pharmaceutical colleagues, where for sure we won't have registration level data. It's going to be very hard to get that. But nonetheless, there is really great data out there showing unprecedented responses, and we owe it to the patients to fight for that. The last bit that I'll just comment on, I'll go through these quite fast because Dr. Sancharawala also already mentioned this, but the antifibril therapy is something that we should continue to follow up on. And there have been many people that have attempted this, sadly failed with the big phase 3s. VITAL and AFFIRM are exemplary here. There is something there, though. I think everybody in the amyloid business can see that buried within the top line data, that these drugs are working. And we know they work also because of the in vitro data and some of the early work with some of the anti-SAP antibodies. I mean, the imaging data there was unquestionable. There are patients in whom we can give them a product that will get their fibrils out of them. So the trick is two things. One is getting better products developed that are more efficacious. And number two is designing better clinical trials with more appropriate endpoints to devise and get the data that tell us what these drugs are actually doing. And it has to be done in the context of all the really great effective anti-plasma cell therapies we have. I think doing early mortality in a trial that would have Mayo stage 1s to 3As with a Dara-Cyborg-D backbone is doomed to fail because Dara-Cyborg-D works so well. So you really have to take patients that haven't had a suboptimal response and study those folks, or plateau in terms of their organ response, and seeing if you can improve upon that further. So I think that that's one of the biggest reasons why the CAL-101 study and the bertamimab study failed, was actually in large part because of trial design. And I think we can learn a lot from that exercise as the new things come forward. And this is my last couple slides, just a good plug for some Canadian content. Paradox Immunotherapeutics is born out of UHN, and these are two young folks that have really wanted to drive this forward and be a little bit more innovative in how they're attacking the antifibril world. They've developed two products. One's for lambda light chains. One is for kappa, which is actually quite a unique approach. I think before it was sort of trying to devise a one-size-fits-all approach, but maybe that's has been a mistake. Incidentally, for those of you that are interested in LEC2, they have an anti-LEC2 product and some other really cool new things that are coming down the pike. But their anti-kappa product, even though that is the minority of AL amyloid, is the one that's the furthest along. And it is showing some really promising data, at least in vitro. So we know it binds to where it's supposed to bind, and we know it binds only to light chains that have amyloidogenic potential. It doesn't bind to light chains with non-amyloidic potential. It goes to the tissues we expect it to, and it's arguably even a cleaner at least immunohistochemically, a cleaner stain than our standard light chain staining. So even this very simple early data is looking really quite promising. And we hope to see this as yet another contender in that antifibril therapy. So some of the mouse data, maybe Paradox will come next year when they've got something to show us that's more than what I can do and do it justice. But suffice it to say, the antifibril therapy is definitely not dead, but we have a new context within which we have to work it in with all of our great anti-plasma cell-based therapies. And with that, I will close with a big thank you slide to all the people that do plasma cell dyscrasia research in British Columbia and other collaborators, Dr. Davis, Margot Davis, who is my cardiology counterpart as an amyloid interested person. And yeah, lots of cool stuff on the way. So thanks very much.
Thanks very much, Dr. Venner, Dr. Sancharawala. You always give a tour de force summary and review of available therapies, and for kind of putting that into focus for us with a Canadian perspective, Chris. That was a great combination of talks, so really, really excellent stuff. We have a minute or two for questions, if there's any questions from the audience. Of course, Victor.
She's a very nice, kind friend of
inviting me.
My last one here in Canada. That was there. And then the question that I have is from all these different treatments that we have, still the stage 3B in particular is the one that we still struggle the most because they died, and they died quickly. So early diagnosis is key. So you could have the opportunity to set up an amyloid screening program. What could you do? What kind of patients could you include? And what would be the best way to screen for that? We're still working on patients with these red flag symptoms, but still, as you know, the fat pad, for instance, which is not invasive, is amyloid load related. So patients that might have too little might not really show anything. We have cardiac imaging tests that are sensitive, but still not necessarily able to pick it up. If we do carpal tunnel syndrome releases, we might have tons of patients like the TTR, but light chain is a little bit less sensitive from that perspective, at least from our experience. So what are your thoughts about what to do in that sense? Because ideally, if you can recognize a group that is high risk to develop amyloid, the next step perhaps thinking about these stabilizers that you could potentially use before the amyloidogenic free light chain gets into the organs in the form of fibrils and get deposited. So I would like to hear from you about your thoughts. And again, thank you for being here.
Thank you for having us. Oh, sorry, so this is already on. I said, give me the microphone. So, you know, it's a great question. I think that I will divide this into multiple aspects. The first aspect is you have to be aware that there is a disease called amyloidosis. If you have, so increasing awareness is that if you have a patient with monoclonal gammopathy of a known significance in your clinic for last 10 years and is now complaining of fatigue, shortness of breath, or leg swelling, please suspect amyloidosis. I had a patient in my clinic was referred by a cardiologist for easy bruising. Nobody tells me, but I get a lot of consults like this, right? Easy bruising, and you know, it was a regular hematology consult. The bruising is right there. So periorbital ecchymosis, which happens spontaneously, macroglossia, again, red flag symptoms, extremely important. Furthermore, if you have symptoms that you can't really, that are multiple organs are affected, heart and the kidneys and the nerves, yes, think of AL amyloidosis. Moreover, you know, we reported, Lisa Mendelsohn, you know, who you know, reported that in multiple myeloma patients, I think we had about 150 patients with multiple myeloma, diagnosis of AL amyloidosis, the median time from symptom onset to diagnosis of AL amyloidosis, these were all patients who were followed by myeloma doctors. You, me, him, you know, we are all myeloma doctors. And they are followed and they were missed. The median time from symptom onset to diagnosis of AL amyloidosis was 20 months. Quarter of the patients were greater than 4 years from the symptom onset. And the symptoms were amyloid arthropathy, macroglossia. They thought that patient had oral candidiasis. So you know, increasing awareness is, I think, most critical. But that is all subjective. So we need something more objective to really, really make the diagnosis early. And I think artificial intelligence is going to come into play. So we do have ECG AI from the Mayo Clinic data suggesting that, you know, in patients who had heart failure with preserved ejection fraction, if they applied this ECG AI model, then the 2/3 of the patients were diagnosed with or suspected or whatever of cardiac amyloidosis at least 6 months before the symptoms developed. We also had from Ultromix, I don't know if anybody from Ultromix is here, which is an ECG AI, Echo AI. Again, a large multinational, multi-cohort validation study differentiating with very high sensitivity, specificity, as well as negative predictive value of patients with HFpEF, hypertrophic cardiomyopathy, LVH, hypertensive heart disease, to differentiate them from all subtypes of amyloidosis. So again, that has gotten an FDA breakthrough device designation. And you know, I think that is going to go forward. So again, those are the AI-based early diagnostic models. Do we have a biomarker-based early diagnostic model? And the biomarker-based models are Amyloid. So that was a presentation at ASH in 2023 of Amyloid, which is a biomarker or an assay of the dimeric light chain constant domain, which is the thermodynamically and kinetically unstable light chain that is potentially amyloidogenic. So you can identify that and really, kind of put that into screening procedure for monoclonal gammopathy of unknown significance for smoldering myelomas. Then, again, Mayo Clinic has also shown a lot of data on N-glycosylation of the kappa light chains, which are supposedly amyloidogenic. So again, that hasn't been really studied, in a prospective fashion. But yes, so there is a lot of things that you could do differently to really not just by subjectively, but unless you think about amyloid, you are never going to find amyloid.
That's a great comment.
I would agree, and I think from a hematologist perspective, because there's still a lot of variability even amongst hematologists for their understanding of this disease. But one of the things that I often tell our fellows and residents as they roll through is if you are ever even in the general heme world and you're seeing MGUS patients, your usual panel of labs should include an NT-proBNP if it's the very first time you ever see them, and pay attention to the UPEP that you ordered, because everybody ignores what the biochemist writes in there. Yes, but in many respects, they can give you the answer. A big albumin band in the urine, if you chose to read that part, is a huge red flag. If you have an MGUS and a huge albumin band, or even a modest albumin band in your urine, that's AL amyloid until proven otherwise. If you have unexpected and unexplained, even a modest rise in BNP, and you're an MGUS patient, that could be your first opportunity to look for amyloid and to prompt those referrals. And the other thing I think is, and Victor, you've done a remarkable job in Calgary of this, is just being available. For us as the amyloid interested folks, and Noel's been trying to do this through the CAS and get the roadmap of those amyloid nerds that are out there that can be available to our colleagues and to encourage them to just pick up the phone and say, hey, does this sound like something that I should refer to you for more formal workup? I think that will go a long way.
Wow, well, I'd love to keep this going because this is a fantastic discussion, but I think just in the interest of time, we're going to conclude here. So I want to thank, again, our two presenters, and Dr. Sanchrawala especially. You've been such a good friend and a supporter to our Canadian amyloidosis community. I'd like to offer you a gift that you may not accept, particularly from Boston.
That's right.
Boston.
Yes,
Can we get a picture of this just so that we can post it on the university website? Yes. So thank you again for coming and being such a great supporter of our community.
Thank you for having me. Thank you.
Yeah. Okay.
Yeah,
we'll conclude now for our nutrition break, and then we'll reconvene at 2:45.
Thank you. Is this really for me?